submitted. If you wish I. Okay.
Good morning, everyone. Thank y'all for joining us. Can everyone hear us okay?
Yes.
Yes, ma'am.
Thank you. Okay, so today we will be going over newborn medicine and assessment. I am here with Dr. Kirsten Robinson. She is our medical director for the newborn nursery here at UMC, and she will be presenting over this topic. At the end, I will share a CNE form for you guys to fill out, and we will get that CNE to y'all.
Fantastic. Good morning, everybody. Thanks for joining. I'm going to go through and feel free to ask questions as we go if need be. And I also have some question and answer time built in at the end, I hope. And so let's get going. Okay, so a couple of our objectives. We're just going to kind of review and understand some of the basics of maternal history as it relates to newborn care, talk about some common newborn physical exam abnormalities that would need to be kind of above and beyond what you would see usually that would need to be addressed. Going to kind of review the proper technique for a newborn hip exam and talk about some current diagnosis and treatment of STIs that are very common in our region, and talk about addressing refusal of standard newborn care practices, and then have some time for questions, I hope. All right, key aspects of the maternal history. We all know this, but it's good to kind of just touch base on this. In our region, there can be a lot of we obviously want our moms to seek and receive prenatal care. There are many risk factors for not seeking care or having less than adequate prenatal care. A big one in our region is access and insurance, having a place where they can go, getting on Medicaid, getting seen, having transportation to those visits, having childcare for their other children. There might be mental health concerns involved, potentially intimate partner violence or violence in the home that they do not want to disclose, and so that keeps them from seeking care. Substance use disorder is a fairly widespread problem in our region also that can inhibit people from seeking care. And so we like to do a pretty good evaluation for our moms that have less than ideal prenatal care to flesh out any of those social concerns that we could potentially get them access to resources that would help with that and improve health access and quality of life going forward. When we move kind of into mom's general medical history, we're really going to assess for any chronic medical conditions. And depending on what those are, would depend on whether we're caring for her in the region or whether we're referring her to maternal fetal medicine. We want to check on things like pre-existing diabetes, gestational diabetes, thyroid and any endocrine problems, any autoimmune issues, so that we can provide the best management for those for the healthiest pregnancy outcome. We want to assess any regular medicines that mom is on, including herbal supplements, if anything, encouraging, of course, prenatal vitamins. We want to take a good mental health history and assess, is mom currently being treated with any mental health medications? Do we need to make any changes to those that are things that are safer to take in pregnancy? A good social history, as we mentioned above, who all lives in the home, do they have any resource needs that we can address, and then a family history, looking for any important things that might play into what we're doing as far as access to care. In her obstetric history, obviously, we're going to want to know about previous pregnancies, mode of delivery, complications. We're going to look at her labs. And then the delivery history, once the baby gets here, we're looking at mode of delivery, rupture of membranes for timing and quality of fluid, and any vital sign issues with mom, complications during delivery. When we skip to the newborn physical examination, obviously we're looking at APGAR scores in the beginning, all the growth parameters, are they small for gestational age, appropriate or large? Which growth charts are we using? There are a lot of different options for growth charts to be used. we have kind of in our system here moved to the Fenton growth charts. That's what the NICU uses. And so we have kind of come alongside that. We're all using the same growth parameters. We're looking for thermoregulation and vitals. I know we're talking a lot about newborn temperatures in transition, making sure that they are warm and dry. And then obviously moving into our head to toe assessment, which is where I want to spend a good amount of our time today. So I didn't feel like it was really helpful to go through like all the aspects of a normal newborn exam. So I really wanted to kind of focus in on some of the more common abnormal things that you might see and any interventions that might be needed for those or considerations so that you are better prepared out in the region to know what needs extra attention and what can we watch and how long do we need to keep that in mind. So lots of newborns have scalp findings at delivery. We're super familiar with caput and cephalohematoma also, but I wanted to talk about subgaleal bleeds also. I think it's helpful to kind of have a picture of where those things are in the actual scalp anatomy. So when we think about a caput, which is super common, which is typically just edema of the scalp. So it can even be pitting edema. It is not typically extremely fluctuant. It can be kind of tense. It is the one that resolves most quickly. And you can have multiple scalp findings at the same time. So if you have overlying caput, it makes it a little more difficult to identify cephalahematomas and early subgaleals and that sort of thing. One of the key findings with caput is it does cross midline and suture lines. So that's going to be a key feature. For a cephalohematoma, that is a collection of blood that is under the periosteum. And because of its location, you can see in this picture, that is why it does not cross suture lines, because it is bound by the periosteum. So that is a specific one that will not cross the suture lines. The subgaleal bleed is the subgalia is a large potential space. This is the one that can get us into trouble if we are not careful. The baby can actually exsanguinate their entire blood volume into this space. And so subgaleal bleeds are important to identify and monitor. So this, a subgaleal, and I have a video late in a little bit that will hopefully show, subgaleal bleeds do actually cross suture lines. They kind of flow over where you would see the cephalohematoma and under the caput. And they often are dependent areas. So if you've got the baby laying on their left side, it's going to all sort of move to that way. If you rotate them to their right side, it's going to start to move the other way. Those are life-threatening and do need to be monitored closely. So if you have a, quote, concerning cephalohematoma that's growing, it's actually probably a subgaleal bleed. So because the cephalohematoma won't cross suture lines, you end up with, if you have a bilateral cephalohematoma, you end up with a baby that looks like they have little horns. And so in this picture, this is a kiddo that has bilateral cephalahematomas, but you can see the area in the middle where it is bound by those suture lines, so it will not cross. In a subgaleal bleed, it's difficult to see when you are just looking at this kiddo, but you can kind of tell that, like you can imagine that he has what you would think is a big swelling, but it's really not until you get in to examine it. And I'm going to see if I can open this little video, and I have to navigate to the actual, we're going to get over to the place where they have a little video of the subgaleal. It's almost, if you think of if you've never seen, there's the pitting edema of a caput. If you can almost imagine there we go. So in a very small, this video is kind of blurry, but in a very small, and this one doesn't have any sound, it's just really looking at that, like a small subgaleal bleed where you can kind of see over on the right side of his skull, when the nurse presses in on the back of the skull, you can see that fluid moving. Here is the kid in our picture where you have a big fluid wave that is moving all the way across this baby's anterior fontanelle. This is a much larger blood volume. And so diagnostically, the way, is that how I'm going to do that? Okay, perfect. Diagnostically, you can often use a head ultrasound to give you a kind of a quick window into, is this a subgaleal bleed or not? And here, our protocol is that we do move those babies to the NICU so that they can monitor their hemoglobin and hematocrit and their vitals. Worst case, and often we are able to just monitor them. It ends up not continuing to bleed. We watch their H&H and they're able to go home. Worst case scenario would be there's essentially a tear that is resulting in that bleed, and neurosurgery would need to be involved. So you want to have that baby in a place where they can get that intervention quickly if need be. Also, if the bleeding is becoming life-threatening, we can get transfusions and all of those things on board. So our process here is to move even small subgaleal bleeds to the NICU just for close monitoring. Does anybody have any questions about scout findings before we kind of move on? Okay. The other fun thing that kind of shows up is called a dacrocystocele. They're not very common. We're used to seeing nasolacrimal duct obstruction where babies get kind of goopy eyes in the first year of life, back and forth between one or the other. But if you have this sort of bluish nodule that appears, it's middle, like just inferior to the medial canthus of the eye. They can be unilateral, they can be bilateral. This is where the nasolacrimal duct has become obstructed at both the superior and inferior ends. And so you have a collection of debris there. This is important because it can actually obstruct the nasal passage. So we usually get ophthalmology involved. They often will eventually go in and probe those, not always right in the newborn period. It depends on the degree of nasal passage obstruction, but these will need to be addressed. They will just generally continue to grow and can cause significant issues. Of note, the kid in this photo also has kind of a flat nasal bridge and hypertelorism, so you could, where the eyes are spaced a little bit far apart, not to address that in this, we're not going to talk about dysmorphic features in this, but that would be an interesting note in this friend, is that the eyes really are too spaced too far apart. And so you would want to kind of assess, are there any other dysmorphic features that this baby might have? When we look at, are the eyes too far apart, we're looking at that medial canthus actually sits outside of the line where the outside of the nares are. That's kind of your general where your eyes should be lined up in the midface. A topic for another day. We see lots of external pinna deformities in the ear, and I bring these up because all of these, most of them are short of microtia, where you have incomplete development of the external pinna and also often an atretic otic canal. These external pinna deformities are mostly cosmetic, but the important thing about them is that they can be addressed non-surgically if we address them early in life, in the first several weeks to a month. So on the left, you'll see the Stahl's ear deformity. That's also called like an elf ear, a Spock ear, for those older Star Trek people. And so that is not going to resolve. That is going to stay in that manner with that extra fold in the helix there. And so ENT can come in and do some ear molding. In the very early newborn period, they kind of make their own molds. As soon as the ear gets a little bit bigger, there are several companies that actually make ear molding. But you also want to be careful about tissue necrosis. So this is something we leave to our ENT colleagues, but they are very happy to see those babies early and get molding started. And that way you can really resolve these anomalies in the first several weeks to a month of life. If we wait too long, the cartilage develops more fully and it's harder to mold the ear, and it takes longer, and there's less of an ideal cosmetic outcome, which may lead to them needing surgery later on. But if you can address them early, it's a very easy way to create a good cosmetic outcome. The lop ear on the right, we see these much more commonly than Stahl's ear, where you have the ear that's folded over. It's okay to watch those kids for a week or two. But if they are not improving, these are ones that we go ahead and send to ENT and they can evaluate them for ear molds. I like that one because it's easy, non-surgical, and usually we're able to get those kids in and make a difference in their life later on. We have a lot of conversations about, can we do routine newborn circumcision? I didn't include here all of the possible anomalies. This is one. This one has had several names over the years, most recently really referred to as penile webbing, where you essentially, the shaft is almost buried into the scrotum. These babies often have a really prominent fat pad. The anatomy inside is often very normal, but there is not enough room to externally to take off the correct amount of foreskin that covers the glands without getting into the skin on the scrotum. And so in this situation, routine newborn circumcision would be contraindicated. You can end up where the glands gets trapped behind a tinted, sort of scarred bit of foreskin, and they can have strictures and adhesions that do not allow things to function as he would love them to when he is older. And so we wait, and these are friends that would need to be referred to urology. It doesn't have to be an urgent referral by any means. Urology is often not going to do a certain, like an in operating room circumcision until after 6 months of age. Part of that is to allow the baby to grow, but the bigger part is that for an elective procedure, the risk of anesthesia in these babies goes down dramatically after 6 months of age. So in elective things, we try to wait. Other things that would fall into this category of normal anatomy variants, but we should wait on the circumcision, would be significant penile torsion. So when the median raphe takes a most often actually counterclockwise turn is generally the way that it rotates. Embryologically, that's got to be the way that it's turning and growing, because that's typically the direction that we see. Penile rotation or torsion more than 60 degrees is kind of a good ballpark of when we should wait on the circumcision. Torsions more than that may not correct on their own over time. And so if urology goes to do the circumcision at a later date, they can also straighten the actual shaft or glands back out, which would help for urine stream and erections and everything to go in the right orientation later. And of course, anybody that has a hypospadias, we're going to wait. Any other urethral anomaly that you can see from the outside, we would want to wait. There are some babies that will have kind of a natural circumcision look where the foreskin doesn't completely cover the glands, depending on how much foreskin is there. Would depend on whether we felt like we could get a Gomco or a Plastibell on safely. So we often wait and defer those to urology as well. If we have to abort a circumcision, if the anatomy looked normal from the outside, but we end up getting in there and there's a hypospadias or something is going on and we need to abort the circumcision, we are often able to kind of obtain hemostasis on the cut edge of our foreskin and just manage it with Vaseline and gauze. And that's also tends to just be a routine referral to urology as well. And so you would want to pull the foreskin back up over the glands, not leave it back where you could have a, phimosis being a problem, and then refer to urology. That doesn't happen very often, but it does happen occasionally. The other one I really like to talk about is very early hemangiomas. So these are what's commonly referred to as capillary hemangiomas, strawberry hemangiomas. So in this baby's left upper arm on the outside, you can see kind of what looks like a hypopigmented area with kind of a little central red. So early hemangiomas do not look yet like the proliferative ones that we're used to seeing in kids that are a little bit older. So, but this is often what the precursor of a capillary hemangioma looks like. It's hypopigmented or pale. you have an area of central telangiectasia. So you can see those little bitty tiny blood vessels, and they're often surrounded by a halo of pallor. So a ring of pallor, and you can appreciate that in this baby. You have a little bit of central redness, and the picture was super clear. Those would be little tiny vessels. And then you have a ring of pallor around the outside. The location is going to determine our management for that. The natural course of that is rapid growth over the first year of life, followed by very slow resolution over several years. The going thought is 50% resolved by 5 years, 70% by 7, 90% by 9, so on and so forth. They, in the very beginning, right after baby's born in transition, they're covered in vernix, their circulation is adjusting. And so sometimes these are difficult to see right away in delivery and transition. And then in your subsequent days exam or later after bathing baby, you'll notice these kind of pale spots. These can also, if you think about like ash leaf spots, there are other hypopigmented spots, but these typically you can see a little area of vasculature in the middle. Sometimes these don't get picked up in the newborn period, and they get picked up as they start to grow and proliferate over the next couple weeks. We often find them in a thorough skin exam, and so I like to explain to parents, this is going to change very quickly over the next several months. It's going to become very red and raised, and kind of explain that, on the arm, this is not going to be an area where it's going to be super problematic for this baby. It's not really prone to a lot of friction or, clothing that's going to bind that. It's easy for the parents to monitor. So this is an area that we probably wouldn't treat. We would let it go through its natural course of proliferation and resolution, and just keep an eye on it over the time. Areas where we need to assess would be on the face, specifically ears, eyes, nose, mouth, around an orifice, if you will, neck, groin, anywhere that's going to be potentially obstructing a structure underneath, impairing vision, feeding, nasal passages. In a beard distribution on the neck, you have to worry about underlying airway or vascular involvement. It's hard to tell at this beginning stage if that's going to be a superficial hemangioma or a deep hemangioma that's going to involve internal structures. If they're on the abdomen or chest, we're going to follow it really closely. If you did an ultrasound, like say you had one on the abdomen that was fairly large, the internal structures are going to be very similar in that they're not going to be proliferative yet. But that's a baby that you might want to do an abdominal ultrasound eventually and really make sure there's not any deep involvement. So for a friend that has one of these on the face in an area that is concerning, we sometimes, depending on the size, will consult dermatology early on to determine if we need to start propranolol or beta blockers are the first line treatment for inhibiting these lesions from proliferating in the first place in an area where they might be concerning, both cosmetically, if you have one that's next to the nose, that can be really deforming of the tissue over time. If you have them in the groin, they are at great risk for ulceration. And so depending on the location would depend on caring for them in the region and getting them in to see dermatology quickly, or transferring them and them needing to start propranolol. This would be one where we often send photos to the dermatologist or the NICU that we can kind of coordinate what exactly is the best case scenario for this baby. The last one we had that was kind of centrally on the gluteus area of the baby, but not near the anal sphincter. And so definitely an area that's concerning for irritation, but one that we can monitor and not start propranolol right away. And so that baby is going to follow a derm in about 4 weeks, and parents have precautions for what to do, and to call if it starts to become concerning sooner. A baby with a large neck hemangioma that is kind of circumferential in a collar or beard distribution, that baby is going to be transferred to the NICU. And we're going to do a full airway evaluation with ENT and start treatment so that we can help mitigate any concerning problems with as that proliferates and hopefully stunt the growth of that lesion. They used to be treated long ago with laser therapy, but that is really more in the proliferative phase later on. The propranolol really helps to stunt the growth. Of course, in a newborn, you have to really monitor heart rate and glucose very closely if you're starting propranolol. So those are friends that we need to evaluate closely. In an older pediatric patient, if they are starting it, they can not necessarily always have to be admitted to the hospital for observation during the initiation of propranolol therapy. They give parents good education about frequent feedings and monitoring. All right. Nevus sebaceous, this is another one we see. They're most commonly on the face and the scalp. They have that kind of waxy, pebbly texture. They can even be flaky a little bit later. You will notice this most frequently because there's not any hair follicles present in the actual lesion. They can be covered by hair. So early on, before they've had a good bath, then you might miss these lesions, and then to be seen later as we kind of move the hair around. So a good scalp exam. They do have long-term potential for some malignant change. They don't need to be followed urgently by dermatology, but just good education for the family, especially if they're on the face or extremities where they're going to be more exposed rather than covered by hair. They will not grow hair in that lesion. Usually that area is not necessarily going to grow in size as the baby grows, and so it becomes smaller relatively in comparison to the size of the baby. Other lesions on the scalp that I don't have a picture of in this lecture would be a cutis aplasia, where you have a failure of all of the layers of the skin to form, and so you have almost like a little ulcerated lesion. These can be seen in conjunction with like trisomy 13 and 18, but we see them most commonly just as a random isolated finding. Those are not traumatic lesions. They can be irritated in birth, but they just need gentle cleansing. You don't necessarily have to put any ointment on them. If they get irritated in birth and you want to clean it well and put some Vaseline on it, that's fine, but they don't typically need any dressings. Hair also will not be growing in that lesion either, but they are not concerning. Those can be anywhere on the skin. They can have a cutis aplasia. We see them most commonly on the scalp. Developmental dysplasia of the hip. So I wanted to talk a little bit about this because we will catching those babies that are at risk for DDH is important, and how to assess them well in your head to toe assessment, and then kind of what we normally do about it. So it is a spectrum of conditions that is related to the hip development in infants and young children. When we think about where the proximal femur sits into the acetabulum, you get a mechanical instability of the hip joint. Breech presentation at any point during pregnancy, but especially in the third trimester, is our biggest risk factor. Positive family history, and then we have to be careful about lower extremity swaddling that bind the hips in adduction or completely straight. We want babies to be able to flex their hips and move their legs freely in a swaddling situation. And so breech presentation is kind of the most important. So we are really looking at the ultrasounds at the anatomy scan and beyond to know what that presentation was especially in the third trimester. We even consider transverse any presentation that's not vertex, where the baby might have their hips in a less than flexed with knees bent position might be concerning. Additionally, we have a kind of a standing plan that we also consider any multiple gestations, even if they are both head down, because they are often in configurations that are space limiting because of their the other siblings that are in with them. So they can have abnormal positioning even if they are vertex, just because of lack of space. So some terminology: a dislocation of the hip is where you obviously have a complete loss of contact between the femoral head and the acetabulum. So the hip is sitting in a dislocated position. You can have a subluxation where the femoral head is kind of moves in and out a little bit, but is not completely dislocated. And then you can have hips that are dislocatable. So it's in the acetabulum, but you can't easily dislocate it with our exam maneuver. So this is an unstable hip. Now, a lot of babies in the very beginning, when we are checking them in the newborn nursery, and in the first couple of weeks, have hip laxity, and this can be normal, but we're going to kind of go through how to do a good hip exam. So subluxation, we talked about, you can, the hips, this is kind of that laxity where you can move the femoral head in and out of the acetabulum, but it doesn't completely dislocate. The reducible is where you have a hip that's dislocated, and with your Ortolani maneuver that I'll show you in a minute, you're going to relocate the hip. So this is like your hip clunk. And then when we talk about dysplasia, we're talking about basically an abnormal shape of the acetabulum. We talk about newborns and often have laxity. It can go away, and we just need to follow them closely. So we're looking at hip instability in our exam, asymmetric leg creases, and functional shortening of the femur, which is a Galeazzi, which you'll see in the video in just a second. All right, we're going to just watch my friend Dr. Lopriato do the newborn hip exam. This is a video that we've been using with our residents and now also with our nursing staff.
Hi, my name is Joe Lopriato. I'm a general pediatrician at Walter Reed Bethesda. In today's video, we're going to go over the proper examination of the hips in a young infant. The reason we want to emphasize this exam is that when we've seen trainees do examinations of hips, we've seen some errors. And the three most common errors are: 1, examining both hips at the same time rather than one hip at a time. 2, improper hand positioning. We see a lot of trainees put their hand on top of the knee rather than at the hips. And 3, we see a lot of motions like rotational motions of the hip or flexion and extension rather than true abduction and adduction, which we're going to demonstrate for you shortly. I hope you enjoy the video.
Let's demonstrate the hip exam on this model. First, remove the diaper. Then we're going to do one hip at a time, so we're going to stabilize the other hip with our hand. Now, to examine this hip, we're going to first flex the knee and put our finger on the greater trochanter. There, the fourth finger on the greater trochanter. Our thumb is on the medial aspect of the thigh. Then once I do that, I'm going to AF flex the hip by pointing the knee straight up in the air. So now I flex the knee and flex the hip. I'm ready to begin. First is the Ortolani maneuver, where I'm going to provide upward pressure and then abduct the hip until the knee touches the table. Then the Barlow maneuver, I'm going to adduct by bringing the knee up to the ceiling there and with some slight downward pressure. So Ortolani is upward pressure and abduct till the knee touches the table. The Barlow, adduct and press down. Up and out, in and down. Always feeling with the fourth finger on the greater trochanter for clunks. Up and out, in and down. Now let's look at the overhead view. Up and out, in and down. Up and out, Ortolani, in and down. Barlow maneuver. Up and out, in and down. And that's the exam of that side. Let's move to the other side. We'll stabilize the hip. I'll flex the knee. Put my finger in the middle of the thigh, my fourth finger on the greater trochanter. Flex the hip by pointing the knee up to the ceiling, up and out, in and down, up and out, in and down, up and out is the Ortolani, in and down is the Barlow maneuver. Up and out, in and down. And that is the exam of the hip on a model. Now let's look at a real baby. First, I'm going to examine if the folds are symmetric on both sides, and I see that they are. And then I'm going to perform the Galeazzi maneuver, where I put both feet flat on the table and measure to see if the knees are the same height above the table. Now let's examine the hip. We'll stabilize one side with our hand, and we'll examine the opposite side. First, we'll flex the knee. We'll put our thumb in the middle of the thigh, and then our fourth finger on the greater trochanter. Now we'll flex the hip by pointing the knee straight up toward the ceiling. For the Ortolani maneuver, we're going to have upward pressure and abduct to the table. Up and out. And for the Barlow, we're going to adduct, so the knee points up, and we'll have downward pressure. Up and out, in and down. Up and out, in and down. Up and out, in and down. And now we'll examine the other half. We'll stabilize the hip with one hand, flex the knee, flex the hip by pointing the knee toward the ceiling. Up and out, in and down. Up and out is the Ortolani, in and down is the Barlow. Up and out, in and down. Up and out, in and down. And that is the exam of the hip.
All right. Okay, so the good thing about having that to kind of have, if you were here in person, we would practice on my models and kind of practice those maneuvers. But I think it's important to note we did a multi-center study that we're doing with our residents with the newborn hip exam. But we also, I think this is an important point for the region, we also did a study of our faculty. Overwhelmingly, we learn, in the see one, do one, teach one kind of methodology. We, depending on who taught us to do the hip exam, we found that we overwhelmingly did not learn correctly. And so now you are well educated on a proper newborn hip exam technique. And you might find things that your colleagues who are not on this video call would find because you are using the proper technique. If you find a baby that has a positive hip exam, our pediatric orthopedic doctors in Lubbock are very passionate about newborn hip health, and so they are happy to get those babies in. The standard would be to send them for a hip ultrasound by 6 weeks of age. If you have a baby that you think the hips are dislocating at this time already, they would be happy to get that baby in sooner. And we have 2 pediatric orthopedic surgeons here in town that are both happy to see those friends. If the hip is just lax or you have risk factors, sending them for an ultrasound at 6 weeks is the standard. And then doing a plain film x-ray at 6 months is also recommended by the American College of Orthopedic Surgeons. That x-ray at 6 months is actually independent of whether or not, even if your hip ultrasound is negative at 6 weeks, it's still recommended to get a plain film at 6 months for our friends who had breech presentation, who have a family history, and so on. We recommend safe swaddling if parents are going to use swaddling that would allow the hips to have room to move. All of their sleep sacks and blankets and those sorts of things generally allow the hips room to flex and extend. And so that we're all about good hip health. Any questions on the hip exam that you can think of before we move on to sexually transmitted infections? Okay. All right. So we, in our region, STIs are extremely common. So chlamydia and gonorrhea would be the most common, and it's important to talk about the difference between those. Moms who have chlamydia that is treated, we're talking about treated, and they don't have a documented test of cure prior to delivery. Those babies we can watch clinically. They're at risk of developing chlamydia conjunctivitis. We're going to encourage those babies to get the erythromycin ointment. Chlamydia can be resistant to erythromycin, so we have to still be careful. Conjunctivitis typically develops between 5 and 12 days after birth. That can be cultured from the eye discharge. It's always a question if you have a baby that has some nasolacrimal duct obstruction also, but the conjunctivitis and eye discharge with, chlamydia or gonorrhea is copious and not just unilateral. Usually it's bilateral and a lot. They can develop pneumonia. It's a subacute afebrile pneumonia, and that can be generally 3 weeks to 3 months following birth. That's characterized by a staccato-like cough. Treatment for both the conjunctivitis and the pneumonia is a oral erythromycin treatment. For the conjunctivitis, they can't just be treated with ointment to the eyes. They need systemic treatment. Erythromycin is known to increase the risk for pyloric stenosis. This is a situation where the benefits outweigh the risk. You just have to know that we're going to give that family good return precautions if we're starting a course of erythromycin, that if their baby starts to develop frequent emesis after feedings, we would want them to come in for evaluation. Gonorrhea is a little bit of a different story when it comes to STIs. The acute illness is 2 to 5 days following birth. You can have ophthalmia neonatorum or ophthalmic infection. And more concerning with gonorrhea is you can have a disseminated infection. So sepsis, meningitis, this is a systemic infection. So in our babies whose moms have a history of gonorrhea and we do not have a documented negative test following treatment, those babies get a single dose of ceftriaxone. This is sufficient to treat an ophthalmic infection, that single dose. We usually go with the 50 milligrams per kilogram. It's not to exceed 250 milligrams in that IM dose. Most of our babies that are in a term nursery are ending up with the max dose, just given their weight. You do have to watch for jaundice with ceftriaxone. It competes with the albumin binding sites for bilirubin. So in theory, those babies can have jaundice. Never have I ever had to start phototherapy on a baby because I gave them a single dose of ceftriaxone for a mom that didn't have a test of cure. You also want to rule out any infectious concerns before you give a baby a dose of Rocephin, obviously. So you would want to make sure that there aren't any other concerns that you would need to address, like a blood culture or anything, before you give the ceftriaxone. Systemic infections require 7 to 14 days of IV therapy, depending on the presence of meningitis. So, for example, if you had just a systemic infection, but you didn't have meningitis yet, you could err on the 7 days. 14 days if they have meningitis. These are the friends that you have to watch for jaundice. And so those are the friends that you're going to be watching really, really closely with their bilirubins as you're treating them for that. Syphilis. I thoroughly recommend anytime you have questions about syphilis, referencing the CDC guidelines. They disappeared for a minute last week with all of the changes, but I did check last night. The STI, all of the treatment guidelines appear to have been rewritten per the mandate and inclusive language removed. And so they're back on the website. So you can now reference those. We're going to go a little bit through because syphilis can be really confusing. And our region is kind of the syphilis capital of the world, right? Or the country right now. So neonates born to mothers who have a reactive non-treponemal, which would be our RPR or VDRL, or the treponemal test, which would be our TPPA, should be evaluated. Those babies should have an RPR performed on their serum. The TPPA, or treponemal pallidum specific antibody, is not recommended in the neonate. It's an IgG antibody, so it crosses. You get passive transfer So if mom has a history of syphilis, the baby's TPPA is going to be positive as a reflection of mom. So the health department will not typically run the TPPA. You'll get kind of an alert in your EMR that says this wasn't run because of the baby's age. A good rule of thumb is trust but verify. I always seek to confirm mom's titers and treatment with the health department. Syphilis is reportable, and so the health department, whether it be the local health department or the state health department, you have access to either one. I have found that the labs for the health department are very willing to talk to me and go through mom's treatment, what they've done, what her titer history is. Now, if she was treated in your facility and you have all of the access to the records and you can see all of that, then you don't have to confirm with the health department. Our moms here often have treatment in various places, and so I don't take anybody's word for it. I'm calling and verifying those things if I can't see the results myself. Infection in pregnancy requires the following things to be true to be considered adequately treated. So penicillin G is the only therapy with documented efficacy for syphilis during pregnancy. This has been an issue because there is a shortage, but it is recommended if moms are pen allergic, they're going to do desensitization therapy, because that is going to be the most adequate treatment. They need to be treated completely per the recommendations and timing based on whatever form of syphilis they have. We'll talk about that in a second. And then we want to see her titer come down, or if she was treated in early pregnancy, we want it to stay low and stable, less than 1.1 to 4. And treatment has to be initiated more than 30 days prior to delivery. And there needs to be no evidence of reinfection. Depending on the severity or the amount of mom's titers, would depend on whether when we talk about 30 days, if she required multiple doses and only got one in before the 30 days, this is a conversation sometimes we have with infectious disease on how do we manage those where it's technically started more than 30 days, but most of the treatment was not. We want to try to head off congenital syphilis as much as possible. Okay, so there are two main forms of syphilis that we're treating in our moms. Early latent syphilis, those moms can be, and this is determined, the health department will help you know which category your mom fell into. So early latent, they can, one dose, single IM dose of penicillin is adequate, and that's lovely. Where we generally run into trouble is our late latent syphilis. Those patients need 3 doses given at 1 week intervals. And when we say 1 week, we mean exactly 1 week. So if you have a mom or a pregnant individual that comes in and they get their first dose on the 1st, and then they don't come back until the 10th for the second dose, they are late and you have to start over. This is where we run into trouble sometimes. And they can get 3 doses, but they're not in the right spacing, and so they're not considered completely adequately treated. There are scenarios that are on the CDC website that will tell you this is the wording of those, whether congenital syphilis. I started with the highly likely. So these are the friends that you're going to, if you can't treat them in your facility with IV penicillin, then this is a friend you're going to transfer. They have anybody that has an abnormal physical exam, so snuffles, long bone concerning findings, those sorts of things, which we most often our patients are not symptomatic in the neonatal period. More often than not, they are asymptomatic. They have a titer that is higher than mom's at delivery, or they have dark field testing or PCR of the placenta. You'll almost never have that third category. We do not discharge our babies prior to getting back the confirmatory testing on the baby if we have sent it. This is where some areas of the state are having trouble because they don't necessarily always have the ability to keep those families in-house, or maybe, I'm not sure. We don't let them leave until we have the confirmatory testing back from the health department so that we can get them transferred and treated so we don't lose them to follow-up. We do a NICU admission for full evaluation. That would be CBC, CMP, long bone survey, looking for any of the radiographic long bone findings of syphilis, and CSF evaluation for VDRL being positive in the CSF. And those babies need 10 to 14 days of IV penicillin. Where it gets a little murky is the like possible syphilis. So the babies have a normal physical exam and their titer is equal to or less than mom's, but the mom wasn't treated properly, or maybe she didn't get complete treatment. She got a regimen other than penicillin, or it was less than 30 days. Those babies also need a full evaluation, NICU and infectious disease consult, and the whole treatment. Similarly with the babies and with the moms, if you miss a day on their treatment, say you lose IV access, you have to give them IM penicillin in that until you get your IV access back, because otherwise you have to start all over. Congenital syphilis are less likely. So this is where it really gets murky in the region. Like, how do we handle these friends? So if you have a baby who has a normal physical exam, their titers are equal or less than mom. Mom got treated and it was more than 30 days prior and she doesn't have any evidence of reinfection. We don't need a full evaluation, but if the baby is seropositive, there's this gray area. We often give these babies a single dose of benzathine penicillin before they leave, and those babies need repeat titers in 3 months and need to be followed until their RPR is non-reactive. This is kind of how we often do this, and then we have them follow with their PCP. If we feel like the need be, we can always get them a follow-up with infectious disease for that 3 months. If we don't think, if they're in an area where we can't get an RPR, we'll have them come back here. Congenital syphilis, unlikely. So mom got complete treated. Her titer is low and there's no evidence of reinfection. And the baby's titer is essentially non-reactive. This baby does not necessarily need treatment. If the baby's titer is non-reactive, we are generally not giving any any IM penicillin here. And we are going to, if the infant has a low titer, we would give them a single dose and follow them until they're non-reactive. If the baby's titer is non-reactive, we are not generally giving a repeat dose and we are not repeating titers. If mom remains seropositive at delivery, so mom's titers say 1 to 2 or 1 to 4, some ID doctors will recommend testing those babies at 2 to 3 months. So they had a negative RPR at delivery, but mom was low and stable titer, just in the off chance that mom had a, subacute reinfection that hadn't been seen yet. Some very cautious people are recommending repeating the baby's titers at 3 months. That hasn't fallen into the official guidelines yet, but a lot of ID doctors are going that route just because we have seen congenital syphilis in the older population that we missed in the newborn period. All right, any questions about syphilis? It can be a crazy one and confusing. I thoroughly recommend every time you have a patient, just rereading the CDC's algorithm and guidelines. That helps it kind of get into our brain. Okay. I wanted to touch briefly on refusal of the common newborn things. We are seeing a great increase of that here, and so I'm assuming that is trickling out to the region also. If a family refuses the state newborn screen, there is a protocol to follow. The family needs to watch. There's a video on the DSHS website or YouTube that is called More Than Drops on a Card. The family is supposed to watch that video. It's a very quick 3 to 5 minute video. And then there's a state form that they need to sign that talks about refusal of the state newborn screen. We don't have very many families refuse the newborn screen. We're usually able to explain it and talk them into that and get that sent. Hepatitis B, we do that on a case-by-case basis. Encouraging them to give the hepatitis B, it only becomes truly emergent and needs to be heavily addressed if mom is surface antigen positive. And I've actually never had a mom refuse hepatitis B who has chronic hep B herself. She understands and does not want her baby to get chronic hepatitis B. That's one that I would potentially get authorities involved because the chronic hepatitis B rate is about 80% if mom is surface antigen positive. Erythromycin, if mom doesn't have the gonorrhea or chlamydia, and we have that documented, we just document that they don't want it and kind of go from there. If mom had, again, I have not had a mom refuse erythromycin who was positive for gonorrhea or chlamydia. Vitamin K refusal, this one's a little bit trickier. So vitamin K is necessary for synthesis of our clotting factors. It is not detectable in cord blood. We talk about it is manufactured in our gut, and our good gut flora is what helps manufacture it. But the most common gut flora in breastfed babies is not the one that synthesizes vitamin K. This takes time. And vitamin K, or breast milk, only contains a very small amount of vitamin K. Formula is actually supplemented with vitamin K. So even though it's not well absorbed orally, a formula-fed baby is being exposed to a constant supplement of vitamin K in their formula. So that is somewhat protective. The parental concerns and reasons for refusal vary widely. Sometimes it's confusion, and they're vaccine hesitant, but when you explain that it's a vitamin, they're fine. There are some, if you go Googling, there's an old study that talked about a cancer link that was refuted, and a gigantic study was done. There is no link. There's a discussion of jaundice and vitamin K. That is only in the dose that we give for newborns, which is 0.5 to 1 milligram. It is not, this is like 30 times the normal dose where you could potentially have some issues with jaundice. And then anaphylaxis can be seen with IV vitamin K administration. That's not how we're giving it to newborns. We're giving it IM or sub-Q. All right. It's also, we call it now vitamin K deficiency bleeding, or VKDB. It used to be hemorrhagic disease of the newborn. I think in an effort to sort of simplify that and help parents realize that it's a vitamin K deficiency. It varies widely. We do see it. We talked about formula somewhat protective. There are 3 sort of onset times. Early within the first 24 hours. Classic is between days 2 and 7. That's the most common. And late onset, which is 2 weeks to 6 months. So when we are having parents sign the form that says we talked about it, we gave them information, I talk about the baby is at risk up to age 6 months. Here, what we've done is we have just printed out the information that is on the CDC website, the frequently asked questions, the info sheet, and I print off the 2 stories about 2 children who have had VKDB. And we have stapled that in a packet. It's available in English and Spanish. And I give that to the parents to review. And then I go over what to watch for at home. I try to give that packet early in the stay, ask that they review it. Sometimes just the packet itself is enough to give them the information they need to give vitamin K. Risk factors for early disease. Interestingly enough, so if mom is on any seizure medications, which they're not often on these particular ones in pregnancy, but we do occasionally have our moms taking aspirin for preeclampsia prevention. And then if mom has been on any antibiotics. Classic disease is the breastfeeding exclusively is your main risk factor. And then you can have some other things in late onset that are risk factors. Clinical bleeding from any site, essentially. The most concerning one, obviously, would be intracranial bleeding. We do see it most commonly in the classic and later onset bleeding. They will often have some warning bleeds ahead of time, or if you have a baby that's having subtle failure to thrive, they can precede kind of the heralding event. And so I give parents good precautions about oozing from the umbilicus. That one is super obvious, obviously. GI bleeding, we talk about mucosal bleeding, and then I talk about intracranial bleeding and what seizures look like in a newborn. I really do a detailed discussion of what focal seizures look like and describing lethargy and all of that. And so anybody that was on the fence, often just in a natural conversation about what they're going to need to watch for, sometimes we'll also choose to give it then. The only recommended treatment in the US is IM vitamin K at birth. Treatment failure is highly unlikely with the intramuscular route, and there's no licensed PO formulation in the US. Parents are often buying them off of the internet. I have a detailed conversation about, you are doing this because you are concerned and want your baby to have all the natural things. We actually have no idea what is in that bottle of vitamin K that you purchased on Amazon. Or at the health food store. We don't know what's in it. We don't know the level, what it's contaminated with. So that concerns me much more than this vitamin K injectable product that we know exactly what's in it, the dose, the formulation. And then I talk about treatment failures in countries that use PO regimens. Compounding pharmacies in the US will make. I always feel conflicted about prescribing PO. I still have them sign the refusal form. If they are adamant about wanting to use PO, we do have a compounding pharmacy in Lubbock that will make it. But I really try to absolve myself of any responsibility for them thinking that the PO is a acceptable alternative in the US. Any questions that I can answer, even on a topic that we didn't address, and any suggestions for future topics? Does anybody have questions about measles, since that is an issue in our region currently?
You can unmute or type in the chat for any questions that you have.
I do want to say that our neonatologists developed a simplified syphilis algorithm. So if anybody is interested in having that, I would be happy to email it to you. If you'll just put your email in the chat, I can send it to you. It's in a PDF form. So I did want to add that to the chat. Dr. Robinson, thank you so much. That was a wonderful presentation.
You are welcome. I'm happy to, please give us suggestions for future topics, and we will add those.
We do have a question. Should a consent be signed before giving vitamin K?
So in our discussions with legal here, the consent to treat actually covers us for vitamin K and erythromycin. And usually the families that, and because there are really no, we don't see injection site reactions, there's not a need for an informed fact sheet for vitamin K in the newborn, considering the millions of doses that are given every year. And so our legal has said the consent to treat covers that.
For hemangiomas, what do we look for in darker skinned babies?
So they will also still have that area of a halo of pallor. The telangiectasia could be more difficult to see, but they will have some subtle pigment variations in those hemangiomas usually. That's a good question.
We can send out the slides and you can put your email address in the comments. And then I put the CNE. If you want the CNE for it, you can fill out that form. I left that in the comments. If you'll just click that link and I will email those out to you.
Well, very good. Thanks for letting me present today, and I hope you all have a wonderful day.
Okay. Hopefully that wasn't too bad.